Hello, my name is Dr. Sherry Ann Muscat. I'm a licensed psychologist from Edmonton, Alberta, Canada. I assess and treat violent young offenders on an inpatient unit in youth forensic psychiatry at Alberta Hospital. I'm also one of the psychologists for Precision Neuroclinics, providing ketamine-assisted psychotherapy. I have formal training and certification in ketamine-assisted psychotherapy, and I'm a certified EMDRIA therapist. I specialize in trauma therapy and neuropsychological assessment and treatment. I also provide psychological services for First Nations people on reserve. Before we begin, I respectfully acknowledge living and working within Treaty 6 territory, the ancestral and traditional territory of the Cree, Dene, Blackfoot, Saulteaux, Nakota Sioux, as well as the Métis. I acknowledge the many First Nations, Métis and Inuit, whose footsteps have marked these lands for generations. I am grateful for the traditional knowledge keepers and elders who are still with us today and for those who have gone before us. I recognize the land as an act of reconciliation and gratitude to those whose territory we reside on or are visiting. Ketamine has at least 5 distinct mechanisms of action that are the focus of current research. The goal of this presentation is to inform researchers and clinicians that advance research and clinical practice across all known mechanisms, as well as explore the advantages of an integrative approach for both research and clinical practice that optimizes and maximizes ketamine's potential, improving treatment outcomes for people with treatment-resistant mental disorders. The authors of this presentation are an interdisciplinary team of researchers, professors, clinicians, psychologists, and psychiatrists. This presentation represents years of research and evaluating hundreds of papers on ketamine across all available research domains for the benefit of frontline psychiatrists, psychologists, and other healthcare workers that need this information, particularly all in one place, but do not have the time or energy to devote to this kind of undertaking. We believe this presentation is a succinct, factual, inclusive repository of information. Ketamine has amazing potential. However, researchers across different fields of inquiry must work together to communicate with openness and respect and collaborate for the good of the people that we serve. Although I am using this treatment model currently in my practice, we do not have enough data to present at this time. However, I can say that as a clinician, seeing the transformation in my patients is indescribable and gives me hope for the future.
I'm Glenn Hartelius, co-author of the ketamine papers. I've been involved in research and publication on the subject of ketamine for about 12 years. My main area of research is states of consciousness, how to describe them, measure them, define them in more effective ways. In this presentation is first a review of ketamine's 5 major mechanisms of action, and on that basis suggesting several best practices for ketamine therapy that will include the elements of patient education, of shaping of patient expectation and intention, considering routes of administration, how to do precision calibrated dosage, kinds of effective treatment monitoring, and the best timing for integrating ketamine treatment with psychotherapy. There are 8 likely contributors to depression, and as you can see here, one of the reasons that ketamine is so effective is that 6 of those are addressed and treated by ketamine's mechanisms of action. Now, of course, ketamine isn't going to do anything for genetic precursors. It isn't going to prevent environmental or biological stressors. But when it comes to glutamatergic system modulation, disrupted signal pathways of mTOR, TRKB, 5-HT2A in the prefrontal cortex, reduced BDNF expression, which is associated with inhibited synaptogenesis and inhibited neuroplasticity, changes in brain connectivity in the default mode network and the salience network and the central executive network. All of those contributors to depression are addressed specifically by the mechanisms, the therapeutic mechanisms of ketamine. So we can look at these in 5 categories. One of its mechanisms of action operates at the receptor level and modulating the activity of the glutamate receptors. Then there is the network level optimization, which impacts brain connectivity, synaptogenesis, and neuroplasticity. In addition, there is a strong anti-inflammatory effect from ketamine treatment. And with higher subanesthetic doses, there is also an onset of increased diversity of brain signals in an entropic brain state and a disruption of habitual cognitive activity.
NMDAR and AMPAR modulation. Glutamate is the primary excitatory neurotransmitter in mammalian brains, serving in about 60% of synapses. Ketamine normalizes glutamate levels, increasing glutamate activity where it is depressed, and decreasing activity whereas it is in excess, particularly in the prefrontal cortex and the hippocampus, and normalizing neural connectivity in the default mode network. This is really exciting, as a homeostatic state is a key factor in mental wellness. For example, in schizophrenia, it is thought to be an overconnection or overcommunication between structures, and depression is less connection or communication between structures. Ketamine balances connectivity and increases synaptogenesis and volume only where there are deficits due to a shearing off or depletion of disorders such as depression.
Ketamine is, as noted, is a brain network optimizer. Depression is associated with a narrowing of brain activity so that it is constrained within habitual limits, and ketamine helps to normalize brain connectivity. It also stimulates synaptogenesis through increased expression of BDNF, temporarily inducing levels of brain plasticity that approach the levels seen in early developmental critical period, which of course enhances the biological support for changes in belief and behavior.
Ketamine is an anti-inflammatory. Pro-inflammatory cytokines can cause symptoms of depression, and ketamine is a powerful anti-inflammatory. As we now know, inflammation may be a key factor in mental disorders, particularly in depression and complex PTSD. Direct effects on inflammation reaction is neuroprotective and promotes neurohealing and neurogrowth. An important mechanism of action is inducing an high entropic brain state. At higher subanesthetic doses, ketamine also induces an entropic brain state with increased signal diversity that may help to disrupt recurrent patterns of brain activity associated with habitual thoughts and responses. High entropy in this context is less organized, similar to a more primitive asleep or altered state of consciousness, whereas a low entropy brain state is associated with high order, more organized, awake states of consciousness. This is akin to a reset button, where rigid underlying negative self-beliefs associated with treatment-resistant depression are disrupted, allowing for the possibility of new positive experiences, laying down new adaptive neural pathways. Ketamine can also induce a transformative subjective experience. The powerful psychedelic experiences that accompany entropic brain states may foster transformative subjective experiences that disrupt habitual habits of thought and belief at the level of experience as well. These new experiences may occur simply as a ketamine effect of the transformative experience of connection, faith, and hope for the future. However, the addition of trauma-informed psychotherapy may install the new adaptive and positive relationship future templates necessary to address underlying attachment disorders and epigenetic factors present in generational trauma, which we believe is one of the most significant underlying contributors of treatment resistance with most mental disorders.
Based on these 5 mechanisms of action, we're going to look at a number of suggestions for best practices with the ketamine-assisted psychotherapy. The first of these is patient education. That gives them information to help prepare their mindset, along with preparation of their expectations and intentions. The next consideration is the treatment context or the setting, which should be managed with consideration for client safety as well as comfort. After that, there are multiple routes of administration that can be used, and the route of administration should be chosen carefully, again, considering the client and the context. Dosage is important and can be calibrated for the desired effect, whether the goal is low dose or transformative. We'll be also looking at methods to determine dosage in a precision manner. Portable EEG can be used to monitor the onset of entropic brain states in order to calibrate what dose is effective for a particular client. In addition, if psychotherapy is to be integrated with ketamine treatment, it can be timed to coincide with the peak synaptogenesis that happens 24 to 48 hours after ketamine treatment.
Patient preparation is very important. That includes education on ketamine's efficacy, the brain effects that ketamine has, and the preparation for ketamine, including what is the ketamine experience and what does integration look like after ketamine. Patient set and setting are very important. Setting an intention before you start, understanding the expectations of this experience, the preparation, and shaping the experience to the personality of the individual. Most negative self-beliefs fall into 3 categories. The first one would be something is wrong or broken, I am broken, or unfixable, or I am a bad person. The second one is I am not safe, fear of death, or unable to save myself. The third one is I am helpless. I am not in control. Ketamine not only disrupts these negative thought patterns, but also weakens the self-protective defenses built up over a lifetime. Ketamine improves the effectiveness and durability and shortens the time necessary for the therapeutic process.
When looking at patient set and setting, the treatment environment is also very important. The physical environment, for example, the space and furniture, the decor, the music, in addition, the social environment, so that the patient can have a sense of safety and be in a relational context with rapport and a caring professional. In terms of the use of music, music with either in the environment or with headset can aid in the integration of the dissociative state or psychedelic experiences. Music should be flowing, it should be uplifting, meditative, and without words that can be understood in the patient's language. Eye shades can be used to support a focus on inner experience without distraction from the environment or from the effect of ketamine on vision, the distortion effects that can happen. In terms of routes of administration, there are 4 that are commonly used for ketamine treatment. Each of these has their benefits and shortcomings. The 4 common methods are through intravenous infusion, intramuscular injection, oral or sublingual, and nasal. The IV infusion has a rapid drug onset. It's easy to keep the drug level stable. However, the cost tends to be high because with an intravenous process, it's necessary to have a medical setting as well as medical personnel. IM injection also has a rapid drug effect onset. Drug levels are high, then decreasing over time. The cost is more moderate because no medical setting is required, even though a medical person to administer the injection is necessary. For this reason, it can be used in a clinic setting rather than in a medical setting. Oral or sublingual has the advantage of being overall the lowest cost. By contrast, the onset of the drug effect is slow, could take 10 to 20 minutes. The drug level is more variable, given that it first increases and then decreases. But the oral or sublingual can be delivered in a therapeutic setting, in an office setting, without any medical paraphernalia. Very similar is the effect of the nasal application, though the onset can be a little faster than the oral. The cost can vary. It can be low cost if a racemic ketamine nasal application is prepared by a compounding pharmacy. It can be high if there is use of a pharmaceutically compounded S-ketamine treatment. There is no difference there's no evidence for difference in efficacy between these different modes of administration. So other factors such as cost, client comfort, and the context that is available should be taken into consideration. In terms of determining dosage, there are treatments that focus on a low subanesthetic dose and others that attempt to provide a higher subanesthetic dose. The difference in terms of the impact on the mechanisms: with the lower subanesthetic dose, the glutamate regulation, the synaptogenesis and induced plasticity, the anti-inflammatory, all of those are delivered with less impact. There is more impact in those areas with the high subanesthetic dose. In addition, the higher subanesthetic dose provides for the entropic brain states, the transformative states, but also the dissociative effects. In terms of dosage, in order to ensure engagement of the mechanisms of actions associated with the entropic brain states and the transformative subjective experiences, it's possible to use a portable EEG monitor to observe when the brain state shifts into that entropic state in order to precisely identify what dosage is effective to bring the client into that brain state and subjective experience shift. If ketamine treatment is part of a therapeutic relationship, then it's important to have the presence of the therapist during treatment, because this not only contributes to patient's sense of safety, but also supports the cultivation of the therapeutic alliance for subsequent clinical work. In addition, the patient defensiveness will be decreased throughout treatment with low subanesthetic dose, or during onset and shortly after treatment with a higher subanesthetic dose, and that state of reduced defensiveness can be used productively for therapeutic engagement. The treatment can also be monitored in other ways besides EEG. Measurement of pro-inflammatory cytokines before and after ketamine treatment can measure the impact of ketamine on symptoms of depression that may be related to inflammation, given that the psychological impacts of inflammation are very similar to those of depression. Also, a scale measuring depression or suicidality can be given before and after treatment in order to measure changes in mood and in the risk of suicidal behavior.
Just to reiterate, timing psychotherapy to coincide with peak synaptogenesis provides optimal support for therapeutic change. Peak synaptogenesis occurs from 24 to 48 hours post-treatment, providing biological substrate that can support change in behavior and belief. Taking advantage of the peak mystical experience through precision dosing and installing new learning during peak neural growth to enhance durable positive effects and create a place of safety, warmth, and compassion. So in conclusion, ketamine may not be as sexy or exotic as traditional organic psychedelics such as psilocybin, peyote, or ayahuasca, but it is perfect for clinical use. It lasts 45 minutes, has the safety record of 50 plus years of experience, including administration to the very young and the very old. And finally, it is available for clinical use right now. In the future, it may be used in group or more naturalistic community settings.
Thank you for your attention, and I would just like to mention that Sherry and I are collaborating on a special issue of Frontiers in Psychiatry entitled Bridging the Gap, an interdisciplinary perspective on ketamine in psychiatric disorders. So if you or colleagues have a paper that is in preparation that you would like to include or submit to that special issue, please contact one of us and we will direct you forward.
Thank you for listening.